There we go. Good morning, everybody. As we get started, and everybody's still coming in from Super Bowl Sunday, Dr. Berlakis is going to talk briefly about the DEFINE study.
Thank you, Serena. Good morning, everyone. Just a 1-minute overview of a study we started about a month ago. This is called DEFINE PCI, and it's a study looking at the use of IFR before and after PCI. As you know, we do IFR to determine if a lesion is significant, but it turns out that if you do it after you put a stent in, the question is, did you do a good enough job or not? And IFR can possibly do that. If the IFR is low after, that means we haven't done a good job either in the lesion or there are other lesions going on. So this is a study that looks at the IFR afterwards and see how that relates to long-term outcomes. Great point. We obviously distal to the lesion we stent, but then we do a pullback at the end as well. Now, it's actually two groups. You know, one is blinded, one is not. So we don't always see what is going on or not. But we typically do a pullback. Of course, if IFR is good, 0.95, 0.97, then we're fine. But if it's borderline or low, then we do a pullback to locate where the problem is. But again, so it's a study. Just want you to be aware that this is a study going on, and it's purely in the cath lab, so you don't have to worry about referring patients. These are people who are referred to the cath lab already. And we'll keep you posted on what we find. Thank you.
And Dr. Gessel was going to be here to introduce our speaker this morning. However, since he's not here, we're going to go ahead and have Dr. Rob Schwartz introduce his son.
That's okay. I'd like to thank the planning committee and everyone here for inviting me to speak today. It's definitely an honor. And I'll just preface this with a lot has happened recently in the tricuspid space, and this ended up being a lot bigger of a topic than I initially planned. So there is kind of a lot of information. If you see something that you want me to slow down on, please feel free to raise your hand. We can definitely elaborate on it. Dad, I apologize. I'm going to be talking faster than you've taught me to speak slowly as I present here, but we'll get going. So I have nothing to disclose, only that I will be discussing some off-label compassionate use and some trial-only device use in this talk. So just be aware of that. Our objectives today will look at a traditional and historical view of TR and the original and existing therapeutic options that have been used for a long time. Then review some anatomy and some pathophysiology. We'll focus on regurgitation. And we'll save stenosis and Ebstein's anomaly for another day. Those aren't anywhere near as common anyway, so I'll leave that to the congenital people for now. And then we'll talk about the novel transcatheter therapies. I've tried to group them into a somewhat understandable organization scheme just because there are kind of a lot of things coming out. So we'll call the first group of percutaneous repair, which is, there's two kind of main ones that we'll discuss, the tri-line and the tri-cinch device, a true annuloplasty device, which is a full ring with a cardioband from Edwards, a leafletplasty, which is a tricuspid clip, very similar to the mitral clip. There's an annular spacer called the forma, and then looking at the full valve replacement, both in the tricuspid position, in the caval position, and then if patients have had prior procedures, you can put the valves inside the ring, and if they've had a full valve, you can replace it that way as well. So you've heard about this many times. Everyone calls it the not-so-forgotten valve, and the traditional mantra was that we should treat all the other valves and then the tricuspid disease resolves, or manage the patient with diuretic therapy alone, and it's usually okay to do it that way. There's tons of data out there now that say that this needs to just be totally forgotten, that mantra should go away. And I would argue that this is really more a neglected valve at this point as opposed to being forgotten. We do get referrals to do these, but they often come too late, and they end up being poor candidates for traditionally in the invasive therapies of getting surgery, and then we end up just kind of having to manage them that way. So in that sense, if we had intervened sooner, maybe we could have done something. There's a lot more attention being focused on the impact of TR right now. It is an independent predictor of mortality in essentially every surgical, percutaneous, and heart failure population that's been studied. This is regardless of LV or RV dysfunction or normal function or the presence of pH. Anyway, if you have TR in any of those settings, it has a negative impact on your outcomes. The importance of annular dilation we'll talk about later, but that is something that we really would like to avoid, and then there are some of the devices that we'll discuss today that specifically address that. And even modest reductions in TR will result in significant symptom improvement and quality of life improvement, and we'll talk about that as well. And so the goal here is to use our innovation, our minds, to create things for an unmet clinical need because it really hasn't been addressed yet. This includes both valvular interventions and some percutaneous therapies. So as many of you know, I came up from the Bay Area, and there's a lot of innovation out there. When I was there, Lyft came out with this new idea about making a shuttle as opposed to just the usual cars, and oh, it's going to be great, and you can all go to work at the same time. But it's important to kind of look back at your history so you realize we don't just want to repeat things. This pretty quickly got canned as well. We're just kind of reinventing the bus, which is a little bit silly. So our goal here is we don't want to reinvent all the surgical things that we've done already. So let's look at our guidelines first. The 2017 update of valvular heart disease from the ACC and the AHA did not address TR at all, so there were no updates from the prior guidelines, which were published in 2014, and we'll go over those in a little bit. The 2017 European guidelines did address TR. They mentioned just a couple of highlights from the tricuspid section are that echo remains the ideal technique to fully assess the valve, although they do talk about MR being utilized for, it's the preferred method to evaluate the RV size and function. And then the indications that you're trying to, when you are intervening, you're trying to avoid irreversible RV dysfunction. Those patients do a lot worse. Secondary TR, they mentioned repair should be performed liberally, and that's a big change from the prior guidelines before that, where it was somewhat hesitant or didn't even really address it that much. And they do mention that repair is preferred to replacement. Both generally, those patients tend to do better. With regard to percutaneous therapies, which is what we're obviously going to be talking about today, they don't address it at all. So just looking at the guidelines, and these are the European ones, they kind of, it's divided out based on whether the patient also has a concomitant need for valvular surgery on the left side. If there's any, the mechanism of the TR, is it primary or secondary? Do they have RV or LV dysfunction or annular dilation? And do they have symptoms or not? And really the only class 1 guidelines are right now are if there's surgery indicated on both sides, although they do kind of hint in the text about this is changing a little bit, and we need to address it more as opposed to just leaving it for the time of surgery. So getting into TR, just a little bit of the background, kind of as you mentioned, we'll just review some of this. It is relatively common. Up to 70% of adults do have at least some grade of TR. It's usually a brief episode during the cardiac cycle. It follows the valve closure, and it has a low signal strength. Abnormal TR occurs usually in the setting with RV overload. This eventually leads to annular dilation and leaflet tethering. In a VA screening study, about 15.7% of patients had greater than moderate TR just in all comers, and only about 8% of those were because of primary valve pathology, so it's usually a secondary process. It's often asymptomatic, and usually it's only detected on echo, which potentially is a reason why it's kind of referred to as a forgotten valve, or like I say, the neglected valve here. So specifically looking at functional TR, which by far is most of the patients that we'll see, it's much more common. These are patients that have normal leaflets and cords. Eventually will lead to dilation of the right atrium and the RV, and later the annulus, and eventually you can get leaflet tethering as well, although this mechanism is not fully defined, and the timing of all of it is still being worked out, but some of the data from this institution has shown that once the RA starts to dilate, that's really the time that you need to start thinking about intervening. It is associated with a lot of other things: pulmonary hypertension, atrial fibrillation, LV dysfunction, and mitral disease. Comorbid conditions can induce pulmonary hypertension and RV dilation. And if they have left heart failure, mitral stenosis or MR, any primary lung disease, left to right shunting, Eisenmenger syndrome, PS, or hypothyroidism, all these patients end up having at least some form of TR. RV disease, if they have infarction in the past or any of the cardiomyopathies, that also can lead to TR. And then there's valvular abnormalities, which we won't really address here, but there's many reasons that they can have lesions on their tricuspid valve itself that are unrelated to any other heart disease. So pathophysiology, the RA is very compliant, and so there aren't any really major hemodynamic consequences, at least initially, with mild to moderate or even up to severe TR sometimes. Eventually, right heart failure symptoms will develop once the TR does get to be severe. That leads to RV systolic dysfunction, and the cardiac output goes down. CVP goes up. This can lead to renal dysfunction, and that can be unrelated to the etiology of your lesion or cardiac output. No matter where you fall on that continuum, you can still get kidney disease. And then up to 90% of patients that have severe TR will have hepatosplenomegaly, ascites, or renal dysfunction. So these are all things eventually we would like to avoid. Evaluating the valve itself, echocardiography is obviously a good place to start. Looking for normal versus abnormal motion of leaflets and the apparatus. RV and RA dilation will happen eventually, but if it's acute, sometimes you can have severe TR and you won't see either of those. And then for the grading, severe TR, you're looking for a vena contracta width greater than 0.7 centimeters and systolic flow reversal in the hepatic veins. However, there is a new criteria that's been proposed for the TR grading. You kind of think initially on the surface is like, oh, those crazy echo people are making more guidelines for us, but it actually is going to be relevant, I think, because they've shown that the qualitative parameters, we kind of, oh, there's some TR, you just say mild, moderate, severe, that'll lead to underdiagnosis here. And so officially, for severe grading, we mentioned the vena contracta width is greater than 0.7, the effective regurgitant orifice area is greater than 0.4, or the regurgitant volume is greater than 45 millimeters. The patients that are being enrolled in the studies currently, like let's take the SCOUT trial in particular, their baseline EROA was 0.85, so that classifies them as severe. At the end of after the procedure was implanted, it was 0.63, so they're still severe. But the patients, despite going from severe to severe, their quality of life, it showed improvement, and the forward flow volumes also improved. So we need a better way to classify these patients after they've undergone the treatment. And so massive TR and torrential TR have been proposed. These cutoffs are based on the gradings for mild and moderate, just to try to get kind of even groupings of each of the categories. And I think it'll aid in demonstrating grade reductions in TR in these studies. So it's not, this was just recently published, and so it's not fully accepted yet, but these are the proposed guidelines for adding on massive and torrential TR. And then also cardiac MR, there's a lot of talk about using that in these patients for a quantitative assessment of the regurgitant volume, the fraction, the RV volumes in the EF, and any associated LV and mitral disease. So if you do have a patient that has TR that you think is going to benefit from therapy, it is worthwhile getting a cardiac MR. I think Dr. Lester will probably agree with that. But so what's the prognosis in these patients? If they have severe TR, it is an independent predictor of mortality. A different VA study looked at 1-year survival. It's about 64%. That's pretty surprising if you haven't heard that before, but that's very low. These are obviously very sick patients and have a lot of other issues going on often. If they do have a low ejection fraction, severe TR is an independent predictor of mortality in that group of patients as well. And if there's just isolated TR, the jet area is an independent determinant of mortality as well. How do we manage these patients? So it's kind of based on the signs and symptoms of heart failure. Basically, you'll titrate your diuretics to try to get their edema down and treat their shortness of breath. The TR jet is very susceptible to loading volumes, and so that can also help. If you're able to diurese them, you will see the TR severity go down. And then also the present and the extent of any other associated abnormalities, you want to make sure you address it. If they have any pH, once they get annular dilation, it's really time to start thinking about some kind of intervention, or if they have any other comorbid disease, you want to treat that as well. So we'll get to the novel options, which are the percutaneous therapies, and then any underlying causes if they have mitral disease or CHF that can also be treated. We often, in these patients, we won't consider really intervening until all the other valves are addressed, which I think is probably appropriate. Particularly mitral disease tends to be the biggest one here. Later stage TR patients, if they do have heart edema, it's often unresponsive to diuretic therapy. That's definitely a good sign when it's time to do something else. And if you do treat the pH, and it has been shown that will reduce their TR grade as well. If they do have mitral stenosis or chronic thromboembolic pH, some studies have also shown that leads to improvement of TR as well. So looking at the ACC guidelines, we looked at the European ones earlier. They are very similar. Your class 1 indications here are only, again, in patients that have left-sided disease, and this hasn't been updated since 2014. It is going to be due for an update very soon, and I think we're probably not quite at the point where major updates will come, but my guess is they will at least address percutaneous therapies in the next round of the updates here. So let's look at our surgical options. Isolated tricuspid surgery, you don't hear about this very much, and there's a reason for that. It's really not well established or agreed upon as to when it should be done or if it should be done at all. The ACC and ESC guidelines are somewhat similar. There's just kind of some minor differences in the wordings, but looking at the two flow charts, it's basically the same. It's only if it's severe TR for ACC and HA. If there's severe TR and their symptoms are unresponsive to medical therapy, it's time to do surgery on it. Or you want to avoid RV dysfunction, so if there's signs that that's starting to begin, it is time to intervene as well. Or if they have any other signs of volume overload, such as congestive hepatopathy. For the European guidelines, again, very similar, trying to avoid RV dysfunction. If they don't have symptoms, it's kind of uncertain. The ACC guidelines kind of mention it. If it's progressive with at least moderate grade TR and they have RV dilation, then it's indicated to do isolated surgery. Very similar for the European guidelines. And then there's also some mention of it might be helpful in pericardiotomy patients if they do have constrictive pericarditis. So what's the rationale to fix it if they are undergoing left-sided surgery? Again, the goal is to try to prevent and improve heart failure symptoms, although there are no data that show any survival benefit in patients that do undergo surgical tricuspid replacement at the time of left-sided surgery. If they do have mild to moderate TR, it is expected to progress in about a quarter of the patients that are undergoing therapy, so it is reasonable to consider at that time. And pre-op TR is a predictor of post-op mortality, and late post-op TR has a significantly increased mortality rate. So it is worthwhile to have your surgeon address this at the same time, as most likely it's going to be mitral surgery as well. There are a lot of risk factors for progression. Just look at those there. And the TR does not seem to add appreciable risk to the mitral surgery. So it is reasonable to consider doing it at the same time. Whereas if you leave it and then they eventually need TR surgery later, that's a very high-risk surgery with up to 10 to 25% perioperative mortality risk. For the isolated tricuspid surgery, we kind of addressed most of this already, but the survival impact is unknown, and there hasn't been shown to be a statistical difference in the patients that didn't undergo surgery. Looking at repair versus replacement, repair generally is favored. It is a much easier surgery and faster as well. I don't know if we have any surgeons here, but maybe they can speak to that. And then recurrent TR post-op after repair is substantial, and the re-op mortality risk is high, so it kind of depends on the patient here. There does seem to be a similar operative mortality risk for repair versus replacement, and the survival rates at 10 years does seem to be similar, but the data for these trials are kind of all over the place. We'll talk about that a little bit later. For the surgical therapies, what are the options here? So they can put in a prosthetic annular ring or a band, and that seems to be the most durable surgical option. There is a biologic repair with one technique where you suture the anterior and the posterior annulus together, or there's a device called the Percutaneous annuloplasty. The K-bicuspidization is interesting because some of the percutaneous techniques tend to mimic this, which we'll talk about a little bit coming up. And then there's a bunch of more complex procedures that seem to be performed a little bit less often, particularly in the recent literature. Operative mortality rates range anywhere from 6 to 14%. Most of these patients are very sick and they're undergoing concomitant surgery on the left side with a 5-year survival of about 64 to 72% and 10-year survival of 44 to 47%. That's not great. And there are a lot of conflicting data, which I think speaks mostly to this being a pretty heterogeneous population in terms of whether they have RV dilation and annular dilation or not. So the mortality rates kind of range all over the place. It's a little bit lower in the modern literature. I think it's more because they're much better about their inclusion criteria and getting a more homogeneous population for those undergoing the surgery. And the survival rates aren't great. The papers are kind of interesting. You'll see these titles of, is this a catastrophic operation? Should we abandon it altogether? I think this argues that we just need a more durable and better option to treat these patients. And as I mentioned, there's conflicting data, and there are some reports of using a homograft as surgeons just trying to find a better way to address this, but it doesn't seem to be working so far. The timing and the risk stratification of the intervention, it's really not well known. This is very controversial in the surgical data. There was a trial that showed a benefit in operating on symptomatic TR before the development of RV and systolic area gets to be greater than 20, or before the patient gets to be anemic. That did show a survival benefit. Risk stratification, the STS calculator does not address tricuspid surgery alone or combined with mitral surgery, so we don't really know that. There are a few others out there that they've tried to create, but it doesn't seem like any of them are very widely used yet. If the patient does have a pacemaker or ICD leads, that's an important thing to address. That can cause impingement or tethering, perforation, or chordae entanglement on the tricuspid valve. Leads to lots of problems, and these patients do have a higher mortality rate than TR patients that don't have leads in place. There are alternative methods of pacing, and the leads can be adjusted, and so it is reasonable to talk to your friendly EP doc to help you. So I think clearly we're struggling here with when to intervene, some durable therapies, and the procedures tend to carry pretty high risk, so sometimes we're kind of left with shaking our heads. Let's see if we can find something. So the interventionalists have kind of come in, and we're going to see if we can tackle this from a different angle, like our bunny heads here. So lots of attention from the interventional community right now. All of these are preclinical. They're very early feasibility trials or first-in-man evaluations, and so we don't have a lot of studies that are powered to show benefit, but a lot of them are showing that these devices are working at least, and just from some of the analysis within them, they do appear to show trends that they're working, but we'll see. The challenge here is that many of these patients have torrential TR, and so complete elimination of the TR is impossible. Keep this point in mind. I'm going to show you a case later where, to the uneducated person, it might look like, well, you still have pretty bad TR at the end of it, but it has been shown that even a minimal reduction in TR, these patients do have some benefit, so it is worth trying some of these early techniques and innovations that they've just formed. So we're still very limited. Standardized and uniform definitions of efficacy do not exist. Dr. Saraja addressed this last week in his talk, but that does make it a little bit difficult to see if are we actually achieving anything here or not. It is a little bit difficult to compare devices directly just because some of them are addressing annular dilation, some of them are addressing the orifice area. Is all TR the same in that setting? We don't really know yet because it's all new. So we're working on it, but I think as we get more data, we'll be able to compare those a little bit better. And then a lot of these patients do have very advanced disease, and so it's challenging to show benefit sometimes because these are very sick patients. So most of them have been deemed non-operative candidates. It's kind of similar to our early TAVR experience. It would be great to see long-term results, but these patients are so sick they end up having a relatively short lifespan. So as we get better with them, I think we'll be able to be treating some less sick patients that have longer lifespans, and that'll allow us to show some clinical benefit of the new devices. So a thorough understanding is needed of the anatomy for percutaneous intervention, and it has to be evaluated, somewhat invasively, but you need a very good 3D spatial understanding. So we'll kind of go through some of that just to understand why these devices were created and how they're hoping to address the TR. It is a very complex apparatus with closely linked structures that hopefully are working, but in this case, obviously not all the time in harmony. It's very similar to the mitral valve, but there are a lot of differences as well. The adjacent structures are very important. They do serve as useful anatomic markers for intervention, and being able to avoid these allow you to avoid complications and hopefully achieve better results if you're able to position things exactly where you want using these anatomic markers or your friendly echocardiographer who's in the lab helping you do all this. For the echo assessment, you get anatomical and functional information, which is useful, and then we're also using CT a lot more, which provides great spatial resolution and a 3D interface, which in some cases you can use in the lab itself, and that will help you navigate to where you're hoping to go. MR still is the gold standard of RV assessment. It's not really used much. Most of these trials, the patients aren't getting MR studies, but I do wonder if in the future we're going to be using that a lot more for anyone that's undergoing tricuspid interventions. So looking at your tricuspid valve here, you have your 3 leaflets. We'll talk about a little bit later. You can have more than that, though. Your anterior, your posterior, and your septal leaflet, and as it dilates, we'll discuss what happens there. Some important nearby structures, your RCA is coming around the top here, your coronary sinus is here, and your AV node is here. Your aortic valve is right over there. So you want to avoid some of these very important things if you're going to be kind of messing around in the RV. And then just a different alternative angle, you can see how close the AV node is, and your RCA is coming right around in front there. So it is the most anterior valve. It's oriented vertically. It has an oval orifice. It's much, much larger than the mitral valve. Just thinking about the cross-sectional area that you're trying to, like if you're going to put a valve in there, as an example for like a SAPIEN 3, the cross-sectional area is about 6 square centimeters. For the tricuspid valve, it's 17. So this is enormous. The annulus does change under varying load conditions. It's fibrous, which is a little bit different. Often in the mitral patients, you'll have like a nice ring calcium around there, or even in the aortic implants as well, whereas you won't have that here. Things you want to avoid are the papillary muscles and the cords. It is tri-leaflet valve. The anterior leaflet is the largest, and it may be notched. The posterior is usually the smallest, and it's often scalloped. You can see up to 6 leaflets, which can make things a little bit difficult depending on which type of intervention you're trying to achieve here. There is a lot of variability in the papillary muscles, and the coronary sinus ostium lies in between the IVC orifice and the septal portion of the tricuspid annulus. That's very useful if you're trying to navigate in the RV space. The RCA is in the AV groove and close to the annulus. There is a lot of variability there. You definitely want to avoid that. There are even some of these devices that they recommend putting a wire in the RCA while you're doing the procedure, just so you know exactly where it is, and it's easy then to inject if you're worried about any kind of occlusion or compression of the RCA. So functional TR, it is a continuum and a dynamic process. It's extremely dependent on heart loading conditions. So diuresis is very important here. Annular dilation will develop laterally along the free wall in both the anterior and posterior directions. So you can see here, this is a normal annulus, and then these red arrows, I don't know, it's a little bit hard to see, but it will dilate out that way. That is important for interventions here, particularly in the tricuspid clip, meaning that if you do end up putting a clip between the anterior and the posterior leaflets, that often won't really help because the annulus can just keep dilating. And so most of the clips that we do are between the anterior and the septal and the posterior and the septal leaflets. It will eventually lose its 3D shape and becomes more circular and flat. It's not really known yet if this is important or not in terms of do we want to try to mimic the natural annulus. You can see it's kind of domed here, whereas in a dilated RV with severe TR, it loses its kind of cusped shape there. Leaflet tethering eventually happens in the setting of RV pressure and volume overload. And this is kind of just a nice schematic of the progression of TR. So you start with a little bit of dilation of the RV, which leads to more TR. You don't really get much RV dilation quite yet. As that gets bigger, the cords get tethered and the RV starts to dilate, and then eventually you'll get some annular dilation as you get more and more severe TR. So with RV remodeling, your risk increases once this becomes irreversible, and with pulmonary hypertension, a lot of these patients would benefit from having a right heart cath to see if there's any reversibility, which will help guide your treatment of the PH. So if you have functional TR with left-sided disease, looking at the timing of when to do any of these transcatheter things, it's important to note whether the annulus is dilated or not, and if that's isolated or not. It is, if the atrial annulus is dilated, that is relatively rare and it's easily repairable surgically, but it should be done before RV dilation or the onset of PH. After that point, if they end up being non-surgical, then it's a good time to do percutaneous interventions. With isolated functional TR after they've had left-sided heart surgery, these are often very sick patients that have had long-standing RV overload and several comorbidities. Replacement ends up being more likely in this case. You often can't repair them just because it's so far progressed. And when patients start having symptoms or when RV enlargement or dysfunction is noted, that's really a good time to start thinking about interventions. So looking at the anatomy, we mentioned about the area. Looking at the circumference, it's about 12 centimeters or so. Because of that, this is a lot different than any existing valves that you've probably heard about using, like sapien valves in the tricuspid space. It's a lot different, and so I think in the long run, dedicated technologies devoted to the tricuspid valve itself are going to be a lot more effective. Because it's so large and the way everything sits in the RV, you don't need to worry about RVOT obstruction like we do when we have any mitral interventions with LVOT obstruction. The leaflet tissue is pretty fragile, particularly compared to mitral tissue, and so that's important if you're thinking about doing any kind of clips on the leaflets themselves. The anatomy is pretty complex. It's rarely calcific, and so that's important for thinking about fixation mechanisms and getting things to stay where you want them to in the proper position in the tricuspid area. And there are lower pressures there, so potentially that means that your fixation is going to be more durable, but you also, we'll talk about it later, but some of the valves need to make sure that there's both forward and backward flow for them to work properly. Some of the adjacent structures, we kind of talked about this, the bundle of His, the AV node, the coronary sinus, and the RCA are all very close there. You want to avoid those if possible. Using 3D echo and CT are going to be very helpful in this setting. And if there's leaflet tethering, that may require a combined procedure to help address all of it. And then, as mentioned many times, the RV failure is a concern when they have developed interventional imaging has kind of become a new field, and there's even fellowships in this now. It's vitally important, but for the tricuspid valve, it's quite difficult. Things that we want to know and are very important for implanting these devices are the dimensions of the tricuspid valve, if there's any angulation of the annulus, slow flow, or if there's a trabeculated RV structure, and trying to avoid those as you're implanting these things. And if there's an annular calcification or not, that's pretty rare, but that does make it a little bit hard to anchor things like we mentioned. So a good starting point is getting a TTE in these patients, moving on to a TEE, getting a CT pre-procedure, and we kind of mentioned nice to consider an MR as well, and then almost all these procedures are guided by TEE guidance intra-op. A couple you can use ICE instead. The American Society of Echocardiography does have some nice guidelines on tricuspid valve imaging. I'll leave the reference here if you want the details, as well as 3D imaging. It is a little bit controversial about which imaging planes to use, but it's mostly just because this is such a new area, and all these interventions themselves require some kind of specific things that you have to image to see where you're implanting them. Particularly the echo views that are useful are the mid and distal esophageal, the shallow and deep transgastric views for both 2D and 3D images. And there's a lot of manuscripts that give you exact step-by-step methods for viewing exactly what you need to look at. Fluoroscopy does tend to be helpful. You wouldn't think so, but it does kind of help you guide you into the chambers and orient your device in the way you want and navigating towards the tricuspid valve, particularly with the clip that we'll talk about soon. And then, as I mentioned, the angiography and making sure you're not obstructing or compressing the RCA is important here. This is just kind of a nice table that summarizes all the different imaging modalities, and we mentioned ICE on there. It helps you navigate sometimes. But, so before the procedure, some planning things that you want to know is it will help you with selection of candidates and which type of device or procedure is going to be most useful. It helps you define the mechanism of the TR that might, let's say if there's annular dilation, you might want to think about one of the annular reduction devices versus if they don't have that one probably won't help you quite as much. It also helps you characterize the tricuspid valve itself, the morphology of where exactly which leaflet, if there's tethering of one of them and not others. It's useful to know. You can look at the anatomic relationships between the nearby structures and the valve itself, and then it helps you determine the sizing of the SVC and the IVC. That's particularly important if you're thinking about implanting valves there. These candidates are often very high risk. They usually have functional TR, which leaflets are often normal, which is nice, but kind of usually that means that you have more options instead of less in terms of potential therapies. Ideally, they have no RV remodeling and non-severe pulmonary hypertension. Those patients don't tend to do as well if you intervene on them. There is, kind of just go over this briefly, we don't have fusion imaging here, but it does make some pretty nice pictures that you can combine your echo with your fluoroscopy. So if you're moving the II, these will move with you. Particularly interesting, I thought, is even the color Doppler images. You can apply those as well. And that'll help you. In this case, they were trying to put a clip in, and you can direct it to right exactly where you're hoping to go. Probably more of a novelty at this point, but maybe in the future this might gain some traction and prove to be useful. Okay, we've been long enough now. Let's get into that. What are the actual therapies that we can look at? So first we'll talk about percutaneous repair, which I would include the triline and the mitral line and the tri-cinch devices. Annuloplasty, the cardioband device, looking at the clip with leafletplasty, form a device for annular spacing, and then the valves. This is just kind of a nice picture that summarizes the different ways of treating this. One goes in the orifice, the valve, obviously you're just replacing the valve, and then the annular device is trying to reduce your annulus size. So the tri-line system, we'll talk about that one first. It's trying to replicate the K bicuspidization procedure with pledgeted sutures along the annulus and the length of the posterior leaflet. This uses an 8 French delivery system in the jugular vein. There's a plication lock device that brings the two sutures together and shrinks your annulus as you cinch it down. There's been a lot of reports of successful use so far, but they are relatively small studies, usually only 10 to 20, I think. And this is done under echo guidance, and you start out subannular with your positioning. The early feasibility trial, the SCOUT-1, was completed for the U.S. enrollment, but it does have an ongoing registry. Looking for a reduction in annular size, EROA showed there was an improvement in NYHA class and Minnesota Living with Heart Failure questionnaire, as well as improvement in their distances in their 6-minute walk test. CE Mark trial isn't currently enrolling in Europe. So this is just a little schematic of the bicuspidization procedure, which is done surgically, trying to do it in a percutaneous method just by putting the two pledgets right along the sides there. This is just a little schematic of how you go through the tricuspid valve, subannular, and come back up and put the pledgets in from the RV side. The two pledgets are put in there, and then you cinch them down, basically getting rid of the posterior leaflet, and you're left with hopefully a smaller annulus and a bicuspid valve now with reduced TR. We are currently enrolling for this trial here. Looking at the criteria, they're all listed here. We've had difficulty getting people approved, unfortunately. It is a feasibility trial, so they are looking for the perfect patients, but hopefully we'll be able to do one soon. Another option is the TriSense system. This is very similar. The only difference is that the placement of where the cinch goes, and then this one is attached to a stent that goes into the IVC that helps apply constant tension to keep that annulus smaller than when you first put it in. It is a relatively large delivery system with a 24-French sheath, but you're in the venous system, so you don't need to worry about any calcifications or anything. The corkscrew is inserted into the annulus. You do have to watch the RCA here very closely. You obviously don't want to put that screw anywhere near the RCA. And then you attach it to the stent. There's a bunch of pull tests where you can check the amount of tension that you have on and make sure you're getting an appropriate amount to reduce your annulus size and not too much. And this can be done under moderate sedation with ice if the operator is skilled in that. The initial reports do appear to be favorable. There have been a couple complications, and these trials have been pretty small so far, so we'll see what's happening with it in the future, but they have completed enrollment in the PREVENT trial in Europe, so we'll see if that's coming soon. But so this is just kind of a nice schematic of the stent, and then it has the tether with the screw at the end of it, which goes in the posterior anterior part of the annulus. And it's tensed up, and hopefully you end up with bicuspid valve there as well. Then for more of a complete annuloplasty, the Cardioband system has been developed. It is currently indicated for secondary or functional mitral regurgitation in Europe. It uses a direct system with a transvenous approach. It can be done on a beating heart, and it's deployed along the posterior mitral annulus, and then it can be adjusted under TE guidance. This has a polyester sleeve that has anchors that you put in on a pre-mounted contraction wire, and then a cinching tool makes sure that it cinches proportionally so the anchors all come in together at an equal amount. This has been shown to reduce MR. It does improve heart failure symptoms and exercise capacity, although the trials weren't powered for showing that, so we'll see that in the larger trials in the future. There haven't been any deaths yet, so we'll see if that happens or not. And they have been able to modify this for the tricuspid space, and it has been shown to reduce the orifice area as well as right atrial pressures, and that's also enrolling in Europe. So just to look at kind of what that looks like, sort of similar to the prior two devices, except a little bit, it's more of a complete ring going all the way around. So I mentioned the two that are the furthest along, or the three, I guess, the Tri-Line, the Tri-Cinch, and the Cardioband. There are some others that are basically just all variations on the same thing, but the trials aren't enrolling for the other three here. So it's a nice little summary of that. Some anatomic challenges of annuloplasty here. As we mentioned, it's very close to the RCA. Your access can be limited here. You can't really go transapically because the RV wall is so thin. The transfemoral route, it is kind of difficult to get under there based on the angle that you have to navigate to get through the tricuspid valve and into the IVC. And the annular diameters tend to be pretty large. These are about twice the size of the aortic devices, and so it can be difficult just to navigate under there. It is difficult to image itself, and again, as we mentioned, there's a lack of standards, so we're not really sure what is meaningful when you get your results. Looking at complete versus incomplete annuloplasty, we have a much more experience with incomplete so far, but there's questions about the durability and the efficacy of that, so it remains to be seen whether the more complete rings are going to be more useful or not. Moving on now, we'll talk about leafletplasty. We have a lot of experience here at MHI with this one. So initially, this was using the MitraClip system and navigating towards the tricuspid valve instead. Abbott has now modified that. It's basically the same delivery system. It's just a little bit, the sizing is a little bit changed to navigate to the tricuspid valve a little bit easier. So ideally, these patients don't have any significant annular dilation with a max diameter of less than 40 millimeters. Usually they have abnormal coaptation, but hopefully it's somewhat preserved just to make this a little bit easier. The coaptation depth has to be less than 11 millimeters and the length of at least 2 millimeters between the target leaflets, which tend to be the septal and the anterior. This is a 24 French delivery system with right femoral vein access. It's done under general anesthesia. It is okay to have an RV lead, but you have to make sure that it's not obscuring your images, or it will prevent the grasping of the leaflets. And also, you don't want it to interfere with your delivery system. One kind of fun mechanism is you can start near the annulus and sort of make like a zipper approach to try to get this to be more effective between 2 of the 3 leaflets, and I have an example of that coming up here. Imaging is obviously very important here. A lot of 3D imaging to help you navigate to exactly where the TR is. And then your final result sometimes can end up looking more like a bicuspid valve in order to decrease the TR. So these are kind of some nice pictures, but I do have some better ones here of an actual case in a minute. So they've done more than 300 procedures worldwide so far. There are lots of great articles describing the step-by-step descriptions of how it's done. It's very similar to the mitral clip that's been done before, which we have a lot more experience with. Ideally, heart failure, mitral regurgitation is all addressed before you get to the point of considering this. And if they do have RV failure or severe PH, that's been excluded from the trial so far. It is very successful, and this is probably driven by just the amount of experience that we have with the mitral clip. And about 91% of patients have shown a reduction of at least 1 TR grade afterwards. No major complications. NYHA class was approved at discharge, and their walk times were improved at 30 days. The Triluminate study is enrolling now. We are enrolling here, and we were actually the first in the world to use the dedicated tricuspid system. So this was after our first case, which was very exciting. So enough about that. Let's take a little break. We'll talk about a specific case. So this was an 86-year-old male that we saw here. Coronary disease with a CABG in the past, severe AS with a SAVR about 9 years after that. And they also added a graft at that time. Presents with some shortness of breath, and he's found to have severe MR and severe TR with some annular dilation and non-coapting leaflets. He does have permanent AFib and had a pacemaker in place, as well as hypertension, hyperlipidemia, and restrictive lung disease. So you're kind of getting the picture. This is probably not a great surgical candidate. He's already had 2 open heart surgeries. He did end up undergoing MitraClip placement in June of this past year. And after that, still had symptoms. His severe TR did remain, as all of the studies have shown. That does happen. And so his pacemaker lead was exchanged for a CS lead in July, and he was still having some symptoms. So he was considered for the Triluminate study, but unfortunately he screened out. And so we decided to see if we could clip it using a compassionate use of the MitraClip system. So this was not a study patient. Pre-procedure, looking at his echo, is showing a severe TR here. Lots of leaking. Doesn't loop. There we go. And on his TEE, kind of the same thing. You can see quite a broad jet there. It is classified as severe, but if you go on the new guidelines, he did technically have torrential TR. Getting into the procedure now, the transgastric views tend to be very useful. And this is thanks to Dr. Bay for these great images here. And on this one, you can see we've navigated with our clip right under the tricuspid valve. And the angling sometimes can be a little bit difficult, but that one's not too bad. And this we are positioning between the septal and the anterior leaflets here. Again, this is kind of looking at the zip technique where you start near the annulus and then you go outwards. And we were able to place one clip between the septal and the anterior leaflets, and then another one a little bit further away from that, and then a final one between posterior and the septal leaflets over here. So there's 3 clips there. We actually did try to put a 4th in because, as you'll see, he did still have a pretty bad TR, but unfortunately the arms on the clip weren't quite long enough to reach that far. And later this year, Abbott is releasing a clip that has longer arms, and so the hope is we can maybe bring him back if he's still having symptoms. So unfortunately, at the end of the procedure, he did still have severe TR, but it was reduced. He was seen in follow-up 1 week later and did report that he was feeling better. I thought this was just kind of fun. It's his post-procedure chest x-ray. So if you look closely here, he's got 2 clips on his mitral valve, 3 clips on his tricuspid valve, a surgical aortic valve replacement, and a pacemaker. So thinking about all the innovation that's gone into this picture is pretty incredible. So we are currently enrolling here. I have all the inclusion criteria here. And we've done 2 cases. Hopefully we'll do some more. So if you have any questions about that, please contact our team. We'll move on to the annular spacer. The forma repair system is pretty, kind of a new and creative way to address this. The goal here is to occupy the orifice area where the blood is leaking through. This is a left subclavian vein approach using a 20 versus a 24 French delivery system, depending on which size of device that you're using. It does have an anchor that's attached to a 42 millimeter long foam-filled spacer that fills the space, and then it's also fully removable. Let's say if they get better and they don't have TR anymore, you can take it out. Right now, there's 2 sizes available at 12 millimeters and 15 millimeters. That's based on echo sizing of the regurgitant orifice area. They are making a 9 millimeter device and an 18 millimeter device, which aren't quite available yet. And these are fully adjustable both in and out of the RV. And it's a little bit harder to move it around, like either septally or anterior posterior, but you can adjust it based on where you anchor your device in the RV. Pre-procedural CT is very useful here just to define your RV anatomy, since you're going to be putting a screw in there. And then obviously interprocedural TE, just like all these things, is going to help you navigate to where you want to go. The leaflets will actually coapt against the device itself as opposed to each other. And there have been studies published that show it is successful. There are no complications. A U.S. early feasibility trial is currently enrolling. And then they've actually even started enrolling for a larger spacer trial that'll have, I think, 75 patients with the goal here. So basically just like kind of like a hot dog that sits in the middle of the tricuspid valve there, and they coapt against it. The pre-procedural CT will show you what angle is ideal for where to place your anchor. It's all done under TE guidance, and you can adjust it based on how things look while you're in the lab to try to reduce the TR as much as you can. The initial trials did show functional status improvement at 30 days, and this was durable at 1 year. Their NYHA class improved in about 86% of patients with increases in their walk times and their KCCQ scores. They did have less edema, and the diuretic doses were decreased, and their BNP levels also went down. 1 patient did have thrombus, but that was in the setting of the subtherapeutic INRs, and this resolved after the Coumadin level was increased and the INR went up. It also showed decreased hospitalizations in essentially all patients that were enrolled, which is great. And the TR improved at least 1 grade in all but 1 patient. And they usually do end up having some residual TR, but as we mentioned, any reduction does appear to provide some benefit to the patients. It's unclear at this point whether you need anticoagulation in the absence of AFib, but they are all getting anticoagulated just in case. And this can also be used in patients with leads in the RV. We're almost done here. Moving on to valve implantation. So kind of 2 different ideas here that are important to note. So orthotopic valve implantation is when the valves go right in the anatomic position of the tricuspid annulus. It's thought that this is more likely to result in complete reduction of TR, but is it necessary to replace it in that position? It's not known yet. It is highly variable, and there's less resistance for fixation than the aortic valve, so this might lead to more specialized and tailored devices to patients as opposed to just kind of where the aortic valve, we're able to use just a few different sizes and kind of use them that way. The large diameters do require enormous leaflet heights to avoid prolapse into the RA, which is a lot different than the aortic devices. And so I do think dedicated tricuspid valves are going to be more important here. The other idea is a heterotopic implant, which does appear to be a somewhat attractive alternative where you're placing the valve somewhere that's not in the tricuspid position. The implantation is a little bit more straightforward. There's a lower risk of structural damage, and you don't need to worry about interfering with any leads since you're not going in that area. So this is an example of a heterotopic implantation with the valve in the SVC and in the IVC. This was just a tailored device that they custom made for, this was a pig. And this was also a different device that they put in the tricuspid position that was also in a pig. So the first human implant with this was a custom device was in 2010. There was a small case series using a Sapien XT in 2013. There do appear to be a lot more coming. And generally these are putting valves in the IVC at the caval atrial junction. It does appear to be safe, feasible, and hemodynamically effective. unclear exactly which approach is best, heterotopic versus orthotopic. We'll just have to see how that plays out, I think. And in order for the valves to be placed in the Caval position, you do have to have proper function there with pulsated blood flow and systolic flow in reversal in the Caval veins. This probably is going to be most effective in patients with preserved RV function because of that requirement. The uppermost IVC does not appear to dilate significantly, so that makes it a really great place to put a valve like this, whereas the SVC RRA inflow does massively dilate, and so anchoring can be very difficult. So some of the devices are only putting them in the IVC, and we'll see if those produce any benefit or not. Not really known for sure yet. The diameters do typically exceed the current commercially available aortic devices, which makes this somewhat difficult. And so when they have been used, often a stent is placed first. Both the XT and the Sapien 3 have been used, and then a German company has made this thing called the Tric valve that's dedicated for the tricuspid space that seems to be potentially more useful. They do make it a little bit larger than the balloon expandable valves. And that involves two expanding bovine prostheses with a skirt around it, the 27 French delivery system, and this does appear to be probably mostly useful in a subgroup of patients that has the flow reversal in the IVC. It has been shown that the TR really isn't addressed that much, and your IVC pressure remains elevated, so it's not clear whether this is going to be beneficial or not. And this is the best picture I could find of the Tric valve, which comes as a two-valve system. So moving on, for patients that have degenerated surgical rings that have had surgery in the past with a bioprosthetic implant, we do have the option of doing valve and valves, or if they've had a ring in the past. Again, this is off-label, but about 8 years post-op after ring repair, about a third of patients will have 3 to 4 plus TR, so a significant number of them potentially could benefit from this. Reoperation does tend to be rare just because these patients are high risk and it's been shown to have poor outcomes. So valve and ring, the largest series so far published, has about 22 patients. They did achieve reasonable results. There wasn't any tricuspid stenosis or regurgitation afterwards. Most patients had improved NYHA class without any mortality. A lot of them do end up having PVL up to 3/4, and this is usually in the area, if they've had an open ring in the past, it usually leaks right around the area that is not covered by the ring. And so many of these patients end up going for another procedure to have that leak closed, and that was effective. But not all rings do appear to respond similarly to when these valves are placed. You are putting a round valve into kind of an oval orifice, so it does make sense that you're getting a lot of paravalvular leak. This is just a nice example of a valve and ring. And you can see the ring is here, the valve sits here, and oftentimes the leak is where there is no original surgical ring, and so they put two vascular plugs there to try to block that regurgitation flow. Looking at longevity, it's thought that for the bioprosthetics, we don't really know the data that well, just because they don't end up undergoing any more procedures, so you don't know what happens to them. Valve and valve does appear to be an option. A small case series has been published that included both the Melody valve and the Sapien valves. The Melody valve was in more younger patients that had congenital issues. Has a low complication rate, about 3/4, had improvement of at least one NYHA class. And then there's a small series looking at using the S3 prosthesis, which is the most advanced that we have right now, and so that probably provides the best results. And it does show that patients they do get improvement when this is done. These are just some nice pictures of the valve in prior valve. And the last one is there's a company called Navigate that's making a dedicated tricuspid atrioventricular valve stent. It's a transjugular and transatrial approach. They've done 3 patients so far. This is one where they do recommend the RCA being wired just because you're getting very close to it. Imaging is going to be very important here as well. And it does appear that you could use this in both functional and degenerative tricuspid disease. With, as we mentioned before, there's less concern about obstruction or anchoring, kind of unlike the mitral devices. They haven't published this yet, so we don't know what the results are, but those are coming soon. And it looks very similar to some of the mitral devices, aside from being much, much larger. All right, we made it to the end. I always thought this is kind of a funny summary, so any guesses as to what TV show or movie that this is summarizing? A girl is transported to a surreal landscape, kills the first person she meets, and then teams up to kill 3 strangers again. The Wizard of Oz? No? Anyone? No? Oh, okay. Not funny. So just some final thoughts here. Large populations exist with functional TR with advanced multivalvular disease. I think we're going to find more and more of these as we get some therapeutic options. You'll have reason to look for it, so we'll see the true numbers. Transcatheter techniques to repair and replace the tricuspid valve seem to be a burgeoning frontier in structural heart interventions. There are some subpopulations that have, I think it's kind of a spectrum, and so as opposed to having just a couple devices, my guess is we're going to have approved multiple different ones to address whatever their specific need is in each patient. And as the left valve is treated, the tricuspid space does seem to be the next conquerable realm that we'll stop neglecting, I hope. For native TR, we're probably a little bit too far off as most of these devices are still in technical feasibility, but I think that'll be potentially coming after that. Important things here: patient selection criteria, echo parameters, device-specific anatomic selection factors, objective clinical and echo outcomes. These all need to be standardized, as well as full and open reporting for us to be able to decide which ones work and which ones don't. Most of these devices will only result in a modest reduction in TR, but that's been shown that you will show some benefit. A lot of these patients are inoperable, and so some of the initial results may not be as positive as we like, but I think as we get able to use them in less severely diseased patients, we'll see some benefit. And we kind of talked about the torrential to severe TR. That does seem to show some improvement. We don't have any randomized trials yet, but they are coming, and there's a lot of technologies that are on the forefront, or that are coming soon, that I think are going to be useful. Just like to thank all these people that have helped me throughout this year, and both with this talk as well. Thank you.
Thank you, Dr. Schwartz. And we have a couple minutes, so does anybody have any questions?
Nice job, Jonathan, and my apologies that I couldn't introduce you properly. There was a school bus in front of me, so
no problem.
Couldn't make it. But first of all, Jonathan is doing a fantastic job in his structural heart disease fellowship. He's our fourth fellow, and probably the best that we had so far, so he's doing a very fantastic job. My question for you is, it seems like we are just unsuccessful in treating functional valve disease, right, with our tricuspid or our percutaneous options, but also surgical options. Mitral doesn't seem to be working out. Tricuspid doesn't seem to be working out. I mean, we're looking at it, but you know how the results are when we try to do this percutaneously. Mm-hmm. Where do you think that space is going, the functional valve therapies, and what are the mistakes that we're making up front, that we are having these patients in surgical procedures and then they show up again with severe TR? Is it a medication treatment? Is the patients not following through? Do we have any ideas why patients show up constantly with these functional diseases that we cannot treat appropriately?
Yeah, I think part of it is probably trying to get effective diuresis. That's going to help more. I wonder if part of the reason we're not doing quite as well is we don't fully understand it, and it's a continuum of disease. And I think if we're able to maybe identify the groupings better, like these patients, whatever, let's say if they have annular dilation, we treat all those a certain way and look at that, and maybe that'll help as well in terms of deciding which therapy or device is going to be best for them. But I do think it's mostly a lack of understanding, and as we get more data, we'll get better at that.
Jonathan, thank you. Very coherent, tough, complicated subject. In reference to MRI, the quantification requires a relatively regular RR interval. Mm-hmm. And so a lot of these people have atrial fib, and they may be decompensated. And that's why you're seeing it not truly part of it. It depends on the individual patient how useful it is. Mm-hmm. And CT, in many ways, actually, we can be more reproducible in how we get it, depending, again, but we can do even very irregular RR intervals with that.
Great. Thank you.
Anybody else?
Just for my own sake and others that might refer patients, what is the pulmonary artery pressure cutoff, and how do you measure that?
Ideally, it's measured with right heart cath, and it's usually 60 is the upper limit, but ideally it's less than that. Those the patients that have lower will do better.
Hey, Jonathan, great talk. I think this is actually a survey to all the clinicians out here. How many of you guys have sent patients for isolated tricuspid valve repair or replacement over your careers, and how many of them? And each one, can you count it in one hand? It's amazing. I mean, it's just so few. But this is, we'll know a lot more in 10 years.
Mm-hmm. I agree.
Anybody else? Thank you very much, everybody. Have a great week. Please stop by and say thank you to our sponsors for this week, Novartis and Otsuka.